Hi, good afternoon, everyone. This is Neeraja. I'm a consultant senior genetic counselor, and it's an absolute pleasure to be back here at the ORDI forum. I have Dr. Shagun Agarwal with me, and and I'm very humbled to have this opportunity. Dr. Shagun, she is the head of the Department of Genetics at the Nizam's Institute of Medical Sciences, and also an important contributor to the developing genetic clinical practice in India. She is not only a geneticist, but she is also an author, researcher, and mentors many geneticists and genetic counselors in India right now. Ma'am, it's a pleasure to have you here and to talk about the preventative strategies in rare diseases, which is a very important discussion that has been going on. And we definitely have definitely need a lot of insights from you. The stage is all yours, ma'am. Please go ahead.
Thank you so much. Yeah. Thanks, Neeraja. And it's my pleasure to be here and to be talking to all of you. So I'm going to start my slide sharing now. So the talk today is going to basically focus on the preventive strategies for rare diseases. So of course, to this group, to the audience, rare diseases are not rare. We all are working in this domain or have a family member affected, or we care for somebody affected with a rare disease. So we know that yes, the challenge in rare diseases is of multiple, it's from multiple levels, multiple aspects. So there are around 7,000 rare diseases known, out of which a majority are genetic conditions. And overall, they do affect around 350 million people across the globe. And although we don't have exact numbers from India, but around 70 to 100 million people are projected to be affected in India itself. And the primary challenge, which kind of exists for the rare diseases, is that, as we see, by the definition, that they're considered rare. But we know from, we especially from in our country, we can realize that nothing is really rare, because we are having a significant burden of individuals who are affected from one or the other of these 7,000 different disorders. And unfortunately, because these are relatively rarer compared to other conditions, so there has been a lacunae in both the diagnostic, the treatment aspects, and many medical professionals are not attuned to diagnosis of a rare disease, or to even suspect a rare disease. And we see how many families go through this long diagnostic odyssey, whereas for years together, there is no answer as to what is wrong with their child. So this is something that the first roadblock which comes to, and then subsequently, of course, after the diagnosis starts the journey towards finding a treatment or some management options, which again is another challenge, because of unavailability of therapeutics for many of these, or even if there is a treatment available, it is extremely cost prohibitive and is out of the reach of majority of people. So due to this, there's a very important aspect to tackling the whole problem of rare diseases, and this is the preventive aspects. And that's something which is more or less, I would say, neglected, because our health system per se is not tuned to, as well as I would say even the patients or the lay persons are not tuned to the concept of prevention. We go to a hospital when something is wrong, but when a rare disease affects an individual, by the time the diagnosis is made, most of the times there is nothing which can be done to help that individual. That's why prevention is even more important for this particular group of diseases, and that's what we are going to focus on today. So prevention, as we know, has various stages. So we have something called as a primary prevention, which is prevention at the level of before onset of the disease or occurrence of a particular condition. Then we have a secondary prevention, which is acts at the level where the disease has basically has happened, but it is not yet symptomatic. So we catch it early so that we can prevent the subsequent manifestations or complications from happening. And then, of course, the tertiary prevention is a situation where the patient is symptomatic, but we are able to help them by an early intervention, an early diagnosis, and an early intervention. So, as far as the rare diseases are concerned, so of course, as I mentioned previously, most of them are genetic. So, here we are basically trying to prevent the onset of a genetic disease, and this is typically done much early, whereby we act in the preconceptional period whenever a couple is planning a baby, or if they are pregnant, we act in an early prenatal period. Then the secondary prevention comes when we are trying to detect in a pre-symptomatic stage, which again has various aspects to it. So it could be a pregnancy screening, or it could be a newborn screening, or it could even be a pre-symptomatic family member detection once an index case is identified in a family. And finally, we have the tertiary prevention, which is a timely diagnosis and treatment of a symptomatic individual. So I'll take you through these three stages of prevention and what are the interventions possible for all these different aspects of prevention. So the primary prevention is basically when we want to prevent the onset of a genetic disease. So this is basically done by what we call as a carrier screening. So a carrier is a person who is asymptomatic but is carrying a genetic mutation, and typically the term carrier is used for an autosomal recessive disorder or a lady with an X-linked recessive disorder mutation carrier. So that's what we are trying to find out. So these carriers for autosomal recessive diseases and X-linked recessive diseases are asymptomatic. They are never going to develop the disease, but they can pass on the mutation, the disease-causing variant, to their offspring, who would then be affected. So the purpose of carrier screening is to identify these asymptomatic individuals who are at risk of having a baby with a genetic rare disease. So here basically, these are the people. So for autosomal recessive disorders, these would be basically the both the partners, because both the partners have to be carriers for the child to be at risk. Whereas for X-linked recessive disorder, it is basically the female partner who would be a carrier. So if we look at an autosomal recessive disorder for which we would like to ascertain the risk. So basically here, both the male and the female partner would be carrying a mutation on one copy of the corresponding gene. That is, they are the asymptomatic carriers, but because they have one copy as normal, so they are not manifesting the disease. But when they reproduce, then there would be various segregations which would be happening for these different alleles. So if a child receives both the mutated allele from each of the parent, like this first child, then I'm so sorry, the pink one is the mutation. So this last child, so when both the mutation alleles are mutated, that both copy of the genes are mutated, then this child develops the disease. Whereas the other possible children this couple could have are carrier children, or could even have an unaffected child where both the normal copies are received by the child. So there are approximately 2,000 such autosomal recessive disorders which are known as of now to science, whereby through asymptomatic carrier parents, the children, unaffected children, could be born. So overall, the risk to a carrier couple is 25%. That is, in every pregnancy, there is 1 in 4 or 25% chance that they would be having an affected child. And with respect to the X-linked recessive condition, so there are 400 such conditions whereby the female partner or the mother is basically the carrier. She is not affected because she has a normal copy of the same gene on the other X chromosome. And then when this couple reproduces, then only the male children would be affected, the female children will not. And again, the risk to the male child would be 50%. So either she would be giving the mutated X or the normal X to her male child. So the risk is 50% for a male child, whereas it's zero for a female offspring. So, but as I mentioned, so there is this huge number of autosomal recessive and X-linked recessive disorder where potentially a couple or a female could be a carrier. So when do we decide that how do we screen, what do we screen for? So we need to apply certain criteria to understand that how do we go about screening for these conditions. So one, of course, we like to look at aspects whether the disease is a severe condition and has a significant abnormality which is not having any treatment available. Then we look at the frequency. So is that disease quite common in the population? Are there many people who are carriers? And then, of course, the other things are related to the availability of services, whether we have an inexpensive, sensitive, and to some extent specific tests to detect those carriers, and what are the options and counseling services available for such carriers once they are detected. So we need to understand whether or to what extent all these criteria are satisfied before we go ahead for carrier screening for any couple. So again, this kind of a carrier screening can be approached in three different ways. So one is at the level of the population, whereby we are applying it to every couple in a universal manner. Whoever is planning a pregnancy, we screen them for certain genetic condition. So again, so mostly people or various different countries have approached it in terms of the prevalence, and the first 2 points, what I mentioned, the prevalence and the severity. So, for example, in Ashkenazi Jews, these are some of the conditions which are relatively common. Again, in the Greek Cypriots, beta thalassemia is known to be common. And similarly, there are certain pockets of certain population groups who would be having certain diseases which are more common there. So for anybody hailing from that population, we would be screening for these conditions. But unfortunately, at present for India, we do not have even the data available for majority of disorders. We know from our experience in the clinic that yes, there are certain conditions which are relatively common, like thalassemia being one example, and many others, but we do not know the exact carrier frequency of each and every condition for our country. And also, we know that we are such a diverse country. So, in different parts of India, different diseases could be more prevalent, or certain mutations are more prevalent. And we do have preliminary information on some of them, but not all of them. So, this is a major lacuna by which it's difficult for us to at present be able to offer a population level screening or a universal screening for the large majority of condition. But yes, we do know that one of the disease which is like the most common autosomal recessive condition in our population is beta thalassemia. So the carrier frequency for that this condition is reported to be 3 to 17% across different parts of India. So which means that, like, here I have made these around 50 individual circles representing females and squares the male. So out of these 50 people, at least 5 are carriers. So even if a couple is not related to each other, they're not consanguineous, still, just because they are Indians, they are at 5% risk on an average of being a carrier of beta thalassemia. And such a couple, of course, they would now be at risk of having a child with beta thalassemia. So, carrier screening for beta thalassemia is something we advocate for every couple who's planning a baby. And this can be easily done by a very simple, inexpensive test that can be set up in any laboratory who has basic biochemistry setup. And this is called as a high performance liquid chromatography for hemoglobin variants, whereby we look at the different types of hemoglobins in an individual. So a normal individual will have majority of the hemoglobin would be HbA, which is the tallest peak you see here. And then there is some small amount of HbF. And what we are interested in looking at for detecting the carrier status is the HbA2. So HbA2 in a normal individual should be less than 3.5%. And here we can see this is a normal individual with an HbA2 of 2.9%, whereas this is a thalassemia carrier whereby the HbA2 is 5.6%. So this is a very simple and inexpensive test which can be done to detect the carriers. So it should be done for both the partners. And once we are able to find that, yes, the partners are carriers, then the next step is to do a sequencing of with the beta globin gene to find the causative mutation. And then once we know the mutation, then we can do prenatal testing in the pregnancy of this couple. So Besides thalassemia, another condition for which our society does advocate for carrier screening for everybody is spinal muscular atrophy. So, around 2% of human beings across the globe. So, this is a pan ethnic condition and not specific to India. So, around 2%, that is 1 in 50 individuals, are carriers of spinal muscular atrophy, which is a significant neurological condition. And here, the carrier screening can be done by a genetic test which is called as MLPS. So this is slightly expensive, cost around 2,000 to 3,000. But then again, this is something which our society does advocate that should be offered as and when available, or at least the couple should be encouraged to attend a center or whereby this facility is available. So these are basically the two conditions for which at present, in absence of carrier frequency data for Indian population, so these two conditions, thalassemia and SMA, we do advocate that universal carrier screening should be done for every couple planning a pregnancy. So besides that, there are certain other ways by which asymptomatic carriers can be detected. So one is a concept of cascade screening. So cascade screening is basically the screening of family members once you have identified a index case in a family. So again, if a particular child is affected with an autosomal recessive disorder or an X-linked recessive disorder, then especially for autosomal recessive disorders, the parents would be obligate carriers, and the siblings of the parents could also be carriers. So these all individuals in the family can also be offered carrier screening to identify their status, and accordingly they can be they can be taken ahead for primary prevention. So this again, this is something which is easily doable in clinical practice by taking a proper family history and making an index diagnosis, and whereby then that particular family who has already seen a child suffering from a genetic condition would be much more motivated to undergo a screening. So this is an example of one such pedigree where you can see this consanguineous couple have two children who are affected with spinal muscular atrophy. So because these two children are affected, this being an autosomal recessive condition, we know that both these partners or the parents are carriers, and similarly the husband's or the father's brother could also be a carrier, and the mother's siblings could also be carriers. So these are the individuals who should undergo carrier screening, and this is something which we encourage all the families to come to us to do. So, carrier screening for SMA is done by this test called as MLPA. So, this is the MLPA report of an affected child, whereby we are looking at this deletion of exon 7 and exon 8. So, this is a homozygous deletion. That's why we don't see any peak here. Whereas the same test can also detect the carriers which are having a heterozygous deletion, and these are, we can see that the peak height is half, and it is not the same as this control peak or the other peaks also. So this is the test which is basically used for detecting the carriers. So again, prerequisite for cascade screening is that first we need to make a diagnosis of the affected person. We need to find the mutation in that affected individual, and then the same mutation can be checked in the other at-risk family members, for which again an important step is to draw a 3-generation family pedigree, because that's how you'll find out who are the other at-risk family members. So, and the third approach to screening is a preconceptual or premarital screening, which is basically again targeted to couples or families who are coming to you for counseling in the right time window. And here again, the strategy is, of course, for everybody, as I mentioned earlier, thalassemia and SMA to be done. But in addition, now we also elicit history of the family. So again, a 3-generation family history. And another important aspect to elicit is consanguinity. This is something which is quite common, especially in the southern part of India. So what do we mean by eliciting family history? So what do we need to ask for? If you just ask a couple, is there any history of genetic disease in your family? They'll say no, invariably, because they don't know what it looks like, right? So it is for the physician or the counselor to ask leading questions for at least some of the common phenotypes which we do see associated with genetic conditions, which could include intellectual disability or developmental delay, history of any thalassemia or other anemia requiring repeated transfusions, bleeding disorders, muscle disease, weakness, any congenital malformations, or even history of recurrent miscarriages, stillbirths, neonatal deaths. So all these are pointers towards a genetic condition, and these should be asked as leading question. And once you have identified the index case, then the testing has to be done in that person first, and then only we can offer risk assessment of the couple. And as far as consanguinity is concerned, so basically consanguinity is associated with an increased risk for autosomal recessive disease, because here this couple who are related to each other inherit a mutation from their common ancestor, due to which they are now carrier of the same disease. So here again the risk of having an abnormal child, if you look at the empirical figure, it becomes approximately double compared to the background risk for first cousins. So thereby now comes the concept of expanded carrier screening. So this is something which at present is not advocated for our population in a universal manner. Main reason being that we are not yet aware of what diseases to include in an ECS panel. So here basically this screening would involve a next generation sequencing based screening to look for mutations in other autosomal recessive and X-linked recessive diseases besides the common ones, or the ones based on family history, and would also include an MLPA for Duchenne muscular dystrophy and a TPPCR for Fragile X syndrome, which are again relatively common conditions. But again, at present, this is not universally offered in our settings. So our society has released carrier screening guidelines in 2023. And at present, we advocate universal carrier screening for only two conditions, and ECS has to be offered in consultation with a geneticist or a genetic counselor only in certain specific scenarios. And then also there has to be a lot of thought into what tests to be offered, and what kind of variants should be considered to be acted upon eventually once the reports are ready. So this is not to be done at present for in a universal manner till we have more information available. So now we go on to the strategy of secondary prevention. So this is the stage where the disease has happened, but now we want to detect it at an early stage so that we can intervene in some way. So here basically there could be three different approaches. So one is a prenatal screening, whereby before the birth of the baby itself, we are trying to look for any genetic conditions in the baby. And then the other aspect is a newborn screening. So once the baby is born, in the newborn period itself, we are doing certain screening tests for that baby, or sometimes it could also be detection of a pre-symptomatic relative of an affected individual. So in these three ways, basically, we are trying to identify early in a pre-symptomatic stage the presence of a genetic condition, and depending on the respective condition, we would be intervening. So first, let's look at the prenatal screening aspect. So prenatal screening primarily focuses on aneuploidies. So what are aneuploidies? Aneuploidies are basically chromosomal abnormalities. And again, in these also, overall the incidence is believed to be around 1 in 200. But within this, the one which is most common is the condition which we all know is Down syndrome or trisomy 21, which is seen in 1 out of 800 newborns. And besides this, we of course have certain other commoner aneuploidies which are there, which are found in a significant proportion of live bonds. So when we are doing prenatal screening, one aspect is to try to detect any of these aneuploidies in the baby, and the other aspect is also to, in addition, screen for certain structural malformations in the baby, which is mainly ultrasound based. So again, these aneuploidies, as I showed, are quite common, but it's not possible to really do an invasive testing or to give definitive diagnostic testing for every pregnancy. So that's where the concept of screening comes. So basically, we use a screening test for every pregnant lady, and this screening test is a highly sensitive and relatively simpler, easily available test. And if this screening test says that yes, this particular pregnancy is at high risk of being affected with Down syndrome or other chromosomal abnormalities, then we go ahead with a diagnostic test. Whereas if our screening test is negative, then we do not really go ahead with any other intervention. So, when all can such a screening be offered? So, screening can be done both in the second trimester and the first trimester. In the second trimester, there are two main modalities. One modality is the biochemical markers, in which basically what we advocate is a quadruple test, whereby four different markers in the maternal plasma are assayed, and then on the basis of subsequent calculations, we are able to say whether the baby is at high risk of being affected with Down syndrome or other common chromosomal abnormalities. In addition to the biomarkers, we also use ultrasound to look for certain malformations. Again, various different malformations in the baby are associated with chromosomal abnormalities, or we also look for certain soft markers, so which are listed here. So, soft markers are per se not malformations. They can be seen in many normal babies also, but statistically, they increase the risk of maybe having a genetic condition. So, there are certain likelihood ratios which are calculated, and then we assess whether a pregnancy comes as a in a high risk or a low risk zone. So in the first trimester also now we can screen for chromosomal abnormalities, and this is mainly in based of using the combined test. So combined test is an ultrasound plus biomarker based test. So mainly three parameters are assessed: NT, which is nuchal translucency on ultrasound, and in the mother's blood, PAPI and free beta HCG. This is done between 11 to 14 weeks of pregnancy, and thereby again you can assess whether a particular pregnancy is high risk or low risk. So these are the test performances for all these different screening approaches. So the test which is typically used in the second trimester is a quadruple marker, which has a 80% sensitivity, that is picks up 80% babies with Down syndrome, but still misses 20%. And the test which is advised in the first trimester is the combined test, which has a detection rate or sensitivity of 85 to 90%. So this screening, so again by definition, a screening test is for everybody. So it should be offered to all pregnant women, because all women, irrespective of their age, are at risk of having a baby with Down syndrome or other chromosomal abnormalities. And then the women who are tested positive again should be offered diagnostic testing. And again, we do not really have any guidelines per se in India yet, but this is something which is very widely practiced across all antenatal care clinics. So now once we have seen how we are using screening using ultrasound or biomarkers to detect at-risk pregnancy, but what next? So the next step, once a pregnancy is flagged as a high-risk pregnancy, so either because the screening test came positive, or when you did the primary prevention strategy, you looked at the couple and found them to be carriers of some single gene disorders, or sometimes couples are found carriers of balanced chromosomal rearrangements, or some lady may be of advanced age or had a previous baby with Downs, which makes her at a priori increased risk for Down syndrome or other aneuploidies, or you have an abnormal ultrasound. So these are some of the scenarios where you would be going for a diagnostic test. So a diagnostic test in this context will always be an invasive test, whereby you will now have to take out the sample of the baby and do a genetic test on that to identify whether the baby is affected with a genetic disease or not. And in case a baby is affected, in majority of scenario, most couples usually opt for a termination of pregnancy. So, what are the diagnostic tests, or how do we obtain the samples? So, the two main modalities. So, in the second trimester, it's called as amniocentesis. Whereas in the first trimester, the test we do is chorionic villus sampling. So in amniocentesis, basically we under ultrasound guidance, we would be inserting this needle into the amniotic cavity and taking out a small amount of the amniotic fluid of the baby. Whereas in chorionic villus sampling, which is done in the first trimester between 11 to 13 weeks, under again ultrasound guidance and local anesthesia, we would be inserting a needle into the placenta of the baby, and then through certain aspiration to and fro suction movements, we would be taking out a few of the placental tissue, and then this amniotic fluid or the placental tissue will be used subsequently for either studying the chromosomes or for extracting DNA and finding the mutation in the fetus. And on the basis of this, we would be able to give a definitive answer whether the fetus is affected. So, but then again, once we make a prenatal diagnosis and we find an affected fetus, the only intervention in majority of cases is to go for a termination of pregnancy. So, which sometimes for some patients may not be acceptable because of religious or personal reasons, or sometimes, unfortunately, some couples have a significant high risk or continue to have repeatedly affected pregnancy. So for such cases, another intervention which is available is called as pre-implantation genetic testing. So whereby first an IVF or in vitro fertilization is done, and the embryos are created, and now these embryos are now tested for the particular genetic mutation or chromosomal abnormality that you want to check in that particular case, and then you select the embryos which do not carry that genetic aberration, and these are then implanted, and then thereby this can prevent the basically the a couple from opting for prenatal testing and thereby for abortion. So again, this PGT is of three different types. PGT SR is basically to test for structural chromosomal rearrangement when one of the parent is a carrier of a balanced rearrangement. PGT-M is to look for single gene disorders, and PGT-A is to test for chromosomal aneuploidies. So this is how from blastocyst, basically a single cell is being taken out, and then a fish experiment has been used, and you can see these three red signals which are basically reflecting trisomy of 21 in this embryo. So now another important intervention which is there is newborn screening. So again, this is now becoming increasingly relevant because now we do have therapies for many of these conditions available, and we do have support also in the form of the National Policy for Rare Diseases for children who are screened at birth and are identified to have a treatable genetic condition. So this newborn screening is done typically at day 3 of life, and the common manageable conditions where early intervention is of benefit, and these are the conditions which can also be easily tested using simple, very cheap assays are listed here. So of which congenital hypothyroidism, although it need not always be genetic, but this is an important condition which is easily manageable. So this can be easily detected in a newborn baby by measuring the TSH levels. And then we have congenital adrenal hyperplasia, hemoglobinopathy, biotinidase deficiency, cystic fibrosis, galactosemia, and even deafness. So these are at least some of the conditions which are quite common, which are easily detectable by using a cheap test and for which intervention is available. This is a bare minimum which should be tested in every newborn. And in addition, of course, we have now a test available which can also look for additional many more conditions. So which includes primarily various inborn errors of metabolism. So approximately 100 such conditions can be detected by a test called as tandem mass spectrometry. And for all these, intervention is available in some form or the other, either a dietary therapy or some other pharmacotherapy. And also it is possible to now screen for lysosomal storage disorders and primary immunodeficiency disorders in the newborn. So the sample which is used for this testing is also a very simple sample. That's just a bright blood spots. So as you can see here, it's being collected from the heel of a baby by a single prick. 5 blood spots are taken on a particular filter paper, and now this spots can be used for all these assays. This can be easily stored at room temperature, can easily be transported to even a distant lab, and can be easily then subjected to assays for these various conditions. So this is again something which needs to be more widely implemented. Again, we don't really have a national policy for this, but many states, especially Goa, Kerala, are offering newborn screening, and also, of course, in the private sector, this is being offered in many health facilities. So another way which we can do an early diagnosis is a pre-symptomatic diagnosis. So typically this is when you identified one family member of being affected with the genetic conditions. In that case, now depending on the inheritance pattern of that condition and the family tree, we can identify who other individuals are also at risk of developing the same disease. So they may be at a younger age, so they may not yet have manifested. So all these individuals can be identified once we know the mutation in the affected person. So first we always test the affected person, and then depending on what mutation was found in that person, we will go and look for the same mutation in other family members who are at risk based on the pedigree. And now these family members, if we are able to find the mutation, so for many of the conditions, we can intervene again by in the form of some drug therapy or in the form of surveillance or certain surgeries to prevent the disease from manifestation. So some of such conditions I've listed here. So for example, Wilson disease, hemochromatosis, again for both of them, treatment is available. For familial cancers, again, the family members could be put on surveillance. For again ADPKD, that is autosomal dominant polycystic kidney disease, a person could be put on surveillance for development of the symptoms or and the renal parameters. And certain lysosomal storage disorders also detecting in the pre-symptomatic state or early symptomatic state can help in early starting of treatment, or even hematopoietic stem cell transplantation at an early stage, which can potentially cure that condition. And again, for many other IMs, early pre-symptomatic stage intervention helps the disease from manifesting. So this is again an important strategy which is easily applicable in the clinical settings once you are taking care of patients with genetic diseases, whereby you should be looking at other family members to find out their status. And of course, the final stage of prevention is the tertiary prevention, which in the context of genetic diseases basically means an early suspicion. So for primary care physician, it is important to know the red flags of a genetic disease. So which would be in the form of family history or consanguinity or type of symptoms, like some of the things which I mentioned earlier, like phenotypes like intellectual disability or behavioral abnormalities, malformations, bleeding disorders, hemolytic or other transfusion-dependent anemias, neuromuscular weakness, ataxias. All these are actually genetic conditions. So a primary care physician is the first person who comes in contact with this patient, and if you're able to refer these patients in a timely manner to a clinical geneticist, they can be appropriately worked up, and they could be offered the best optimum management which is available for that particular case. So delay in the diagnosis, delay in referral causes irreversible damage, and then it is becomes more challenging for the patient to be able to access care. So in this context, then I would again like to mention about the national policy for rare diseases. So this is really, I would say, um, one of its kind policy in the world, which has been launched by our government, and for patients with rare diseases to help both the preventive aspect as well as the treatment aspect for rare diseases. And this policy was implemented in 2021, and this to some extent takes care of the cost factor, which was a big burden previously. So very often we know that, sometimes primary care physician is able to suspect a genetic disease, even diagnose it. But then there is this attitude that there is nothing which can be done and there's no point in doing anything. And they just tell the parents to, kind of that nothing can be done for this child, and to, go ahead with a fatalistic kind of an approach. So that is something which now is changing and has changed for many patients affected with rare diseases, because this policy offers treatment support for many of the conditions. So under this policy, there are 15 centers of excellence which have been recognized, and the policy also has various aspects with respect to research, with respect to infrastructure support, training of health personnel. But the most important aspect for patients is the treatment support. So for every patient with a rare disease, a 50 lakh amount is given towards their treatment, and this is really a boon for many patients. So there are three different groups of diseases which are provided for in this policy. Though, so the group one is basically diseases amenable to one-time curative intervention in the form of hematopoietic stem cell transplantation. So here many common diseases like lysosomal storage disorders, inborn error of immunities, and certain other bone marrow conditions come in picture. And then liver transplantation for certain liver conditions and other IEMs, and renal transplantation for renal genetic conditions. So these are basically interventions which are one-time interventions, and these are completely covered under the policy. For the group 2 diseases, again, these are most of the times, these are conditions which are inborn errors of metabolism, but there are certain other conditions also, as you can see here. So these are benefited by usually by a long-term or a lifelong treatment, but there are easy interventions in the form of dietary formula or certain drug therapies or hormones which are available for these conditions. And these all are again financially supported under the policy. And then the group 3 diseases is again conditions which are somewhat common. Yes, do see, especially Duchenne muscular dystrophy and SMA, spinal muscular atrophy, are very, very common. But for this group of condition, treatment is somewhat challenges. So the cost usually is very high here, and most of them require lifelong therapy. For some, there is definitive benefit, like what I have listed here, 3A. These are basically disorders requiring enzyme replacement therapy, and that does show significant clinical benefit. Whereas for others, although some therapies are available, but the definitive benefit is not yet established. So this is the portal for the National Policy of Rare Diseases, and here we can go and look at the various institutions which are the centers of excellence and which can be approached if there is an affected patient. So our institute, Nizam's Institute, along with CDFD, is also a joint center of excellence, and we have already received applications of 662 patients towards financial support, and at present we are treating 178 patients completely free of cost through provisions of this therapy and this particular policy. And these are the various conditions for which treatment is at present ongoing at our center. So with this, I would like to come to the concluding slide. And first important point, which I've tried to make is that prevention is an important modality. So because yes, of course, with the policy, treatment support is available, but it doesn't cover all the diseases. For some diseases, again, a large majority, in fact, treatment is not yet available. So prevention in the form of the primary and the secondary prevention is what is very, very important. And this is what is going to make a larger impact in terms of reducing the burden of genetic diseases. And of course, primary prevention is ideal, but not always possible. But yes, we should aim to achieve this. Secondary prevention is something which is available, but again, of course, there are certain limitations. So it's important, of course, to for a primary care physician to suspect early that a patient could be a potential rare disease patient, and to refer them early to a geneticist or to one of the center of excellence, whereby an early diagnosis can be made. And for a prospective couple, it's very important to refer them in the the best time window, which is pre-conceptual period or early prenatal period at least, whereby that's the time when we can investigate, when we can intervene and have the maximum impact. So with this, I would like to end.
Thank you, ma'am, for a very lovely presentation and a very good discussion. And yes, I think it's in addition to the fact that we have very limited treatment options, there is also a huge burden on the families who are dealing with rare diseases, both from a financial perspective, but also a lack of social services and lack of acceptance in the society, which right from education to inclusivity, which makes it really difficult for families to seek support. And as all of us have interacted with families, we've seen a huge fallout in the treatment and in getting the support itself for these family members. So prevention would be the key factor when we're looking at rare diseases. There are a few questions, in two particular questions that I wanted to bring up by someone called Mr. Vikas Bhatia. They asked about a role of a gynecologist in OBG to prevent rare disease, which is, I think, a great question. Second one is, can late marriage and environmental factors trigger rare diseases in an Indian perspective?
Yeah, so first coming to, the first question, which is a very, very relevant question. So in fact, an obstetrician is the person, who can offer the primary prevention, right? Because an obstetrician is the one a family goes to when they're planning a baby or who are already pregnant. So more than any other healthcare practitioner, it's the obstetrician who has a huge role to play here, actually, because they're the one who would be seeing this couple for the first time. So they should, it should become a practice for every obstetrician to take a family history. That's extremely important. And also, all the red flags which I mentioned, to ask leading questions of all those different factors which indicate genetic disease, and then of course refer them at the right window. That's very important. Very often we see that an obstetrician does refer a patient, but they refer the patient at the stage of, like, let's say between 16 to 20 weeks, without the workup of the index child. They would directly be referring the patient for an amniocentesis. So that's a time when we cannot do anything. So we really need to get these patients, or be able to flag these patients and refer them in the pre-conception or very early prenatal period, because that's when we will be doing the testing and we'll be finding what's wrong or in that particular family, and then only we can do the next step. So it's really, really important for the obstetricians to become aware that yes, what do they need to ask? I mean, I would say the basic thing is to ask family history and at least offer carrier screening for thalassemia. I mean, we know that with awareness, everybody offers screening now for Down syndrome, because that also was not there, like 10, 15 years from now, that was not being offered. Now almost every lady has a Down syndrome screening done. But thalassemia is something which is, I would say, criminal to not offer thalassemia screening. It's something which is as common, maybe even more common than thalassemia in India. We need to offer carrier screening bare minimum for thalassemia.
Absolutely
And
agree, ma'am. I
yes,
think that's key. The next question was about, can late marriages and environmental factor trigger rare disease in an Indian perspective?
yeah, so I think it maybe not in a huge manner. I mean, environmental factor again. Um, I I mean, as far as the the pure genetic conditions are concerned, whereby we have the mutation at the level of the genes or some chromosomal abnormalities. So usually, environmental factors do not really play much role there. Of course, environmental factors do become important in multifactorial conditions, but those are, like, not really considered to be that rare or purely genetic. But late marriage, yes, I mean, at least in certain socioeconomic strata, it is becoming more prevalent, we know, and that does increase the risk somewhat for the chromosomal disorders, predominantly Down syndrome. So yes, there is likely to be some shift there in a particular socioeconomic strata, but again, in the context of the whole country and our heterogeneity, I don't think it would be a major tipping point for us right now. So I feel that we are more grappling with the aspect of, because we are so much inbred, and with also consanguinity being there in large parts of India, I think the main burden for us is the autosomal recessive conditions, and for which the primary prevention by carrier screening is what we should be aiming for, and that's what is the main burden for us.
Absolutely. The other question, which I think all of us are trying to answer, is why universal screening, newborn screening, is not in India apart from Kerala and Gujarat.
Yeah, so I mean that's something which all geneticists have been advocating for years together. But I mean I think that's the problem, that rare diseases are considered to be really rare, and the awareness is not there at the policy level. So that's what's happening. That the universal screening has not come in yet. We now see that now, at least for the sickle cell disease, universal screening is slowly, at least for the tribal population, it is getting implemented because of the policy. So that's something which is there. But we hope that, yeah, really, I mean, this is something which would soon get implemented. Let's hope for it. Yeah.
Yes, that's what we're all advocating for. Uh, One last question that I have for you is that we are seeing a lot of people who are now, general population who are actually coming up and asking for, preconception carrier screening, or want to explore the idea of genetic testing even before they get married. So pre-marital screening. And it's very nice to see that shift, because we're not just looking at awareness from a physician or a clinician standpoint. So the onus is not just on them anymore, but it's also slowly shifting to the general population, because many people are now aware that these kinds of tests are available or can be done. So not just families who are products of consanguinity, or children of consanguineous parents, but also couples who are looking to marry want to now start exploring, and we've definitely seen more influx of these cases. So what is your opinion for prevention strategies for these kinds of
So, I mean, again, the caveat which I mentioned for carrier screening for us is that we do not yet have enough data available, as in, like, what all conditions to screen for, and also because we are such a diverse population, so there would be pockets of certain conditions in certain groups, in certain populations, certain states, certain linguistic groups. So that's something which again is yet to be explored. So with the Genome India project, we hope that we'll get more information, because now we have the genome representation from different parts of India. So I mean efforts are ongoing to kind of find that the missing key thing, I mean whatever the data which is really sorely lacking, because that's what we will be then basing our career screening approach on. So again, in today's, I mean, at least for me, when patients come to me, so I mean, of course, thalassemia SMA is what we offer everybody. I feel that if some couple is, I mean, affordability is not an issue. They're aware and they're motivated. We could, in addition, offer carrier screening for DMD, Fragile X, which again we know are pan-ethnic and somewhat common conditions. But beyond that, we do not really, at present, I don't think we don't really advocate an expanded carrier screening using exome sequencing or other NGS-based method for a low-risk couple. So low-risk couple, I would say, is a couple, who's non-consanguineously married, doesn't really have a significant family history. So those are two key things that we should have taken the family history properly. Again, that point that gets missed. So when we say screening, we always think of test, but as clinicians or counselors, it's also important that we should have taken a proper family history, because so many times that gives you important clues, and then that there is a risk factor in a family. So again, that's a family pedigree, a 3-generation family pedigree is an important screening tool. So I would say, for everybody, thalassemia, SMA, and a 3-generation family pedigree, that's basic, which should be done for everybody. Beyond that, I mean, again, depending on the motivation and other factors, so probably DMD or Fragile X we could offer to some couple. But ECS, or I mean NGS based testing, is something which is very tricky, because we all know that it gives rise to so many variants of uncertain significance, which create more anxiety and more scenario where we don't know what to do, but then unnecessarily it kind of, complicates the couple, causes so much anxiety for them. And something like a pregnancy, which should be a, a happy event or a happy this thing, becomes a constant state of stress. So unless we have more data available on, which disorders to screen for, and also for the variants also, because we still many of the variants which get flagged as variants of uncertain significance are actually based on the normative data of the Western population. So those same variants may be just for our population, maybe just a polymorphism, so we don't know all those things yet. So and so that's why you are more likely to end up with a loose list of variants of uncertain significance, and then it would leave you nowhere. Kind of we cannot act on them, but then again it creates so much of anxiety. So we need to kind of offer it very judiciously. So mostly if a couple does have a family, some significant history, and or a couple is consanguineous, there was a previous child with something which looks like a genetic condition, and the child is not available for testing. So certain scenario, we would advocate to do, an NGS based expanded carrier screening, but not as a routine. We are not ready for it yet.
Absolutely. Yes, as we were talking genetic counseling school, that your pedigree or your family history is your first tool for any kind of
Yes,
screening, and that has to be put
absolutely.
at the first point. That's great. And someone
Absolutely.
also left us a comment that your work screening has started in Assam, that which is great, and they are also
Okay.
available for 5 disorders.
Okay, that's great. That's great.
Good.
Good to know.
Okay. So I don't think we have more questions, and we are about the time that we want to wrap up. Thank you so much, Dr. Shagun. This was a very informative discussion and quite well detailed and really well presented. Thank you so much for enlightening all of us on this topic.
Thank you so much. My pleasure to be here.